Thank you, sir. So it's 8 p.m. here, and I welcome you. And we are going to start. I welcome to all my dear participants, and as well as our today's speaker, who is Dr. Sridhar Kalyanam Sundaram. And today we are going to start our another webinar session on the conjugated hyperbilirubenemia and its approach by our speaker, Dr. Sridhar Kalyanam Sundaram. Sir is a consultant neonatologist and head of department at the Nath Al Imarat Hospital, Abu Dhabi. And he's completed his basic medical education from India in 1995. He is the best outgoing student from the Stanley Medical College, Chennai. Sir qualified in pediatric and neonatology in India. He completed the MRCPCH UK and obtained entry into the General Medical Council Specialist registered in the UK in 2005. Dr. Sridhar Kalyanam Sundaram obtained his fellowship of the Royal College of Pediatrics and Child Health UK in 2006, and he worked as a specialist registrar in neonatology at Edinburgh's NHS Trust Hospital, Cambridge, UK from 2004 to 2005. From mid-2005 till August 2012, Sir worked as a consultant neonatologist in Level 3 neonatal unit at Bishop General Hospital near Glasgow, UK, following which he moved to the American Hospital, Dubai. He worked there as a consultant neonatologist and head of department till 2017, followed by Zuleika Hospital and Al Zahra Hospital, Dubai. Since May 2021, he is head of neonatology at the Nath Al Imarat Hospital, Abu Dhabi, and he is also examined for MRCPCH clinical examination since 2010 and is NRP instructor as well. And his special interest includes neurodevelopment and respiratory support in neonates and in neonatal skin care, and has many review publication as well. And he has organized and chaired the scientific committee of the many international conferences. And he has also our own YouTube channel for education purpose. Previously, it was close to 10,000 subscribers, but yesterday it was 15,000 subscribers. So congratulations, sir. So over to you, sir. Thank you.
Thank you. I hope you can see me and you can see the slides.
Yes, sir.
Yeah. First of all, thank you very much for inviting me. I know I get a lot of love from Pakistan and all the colleagues there. I mean, and obviously in UAE, we work together. It's amazing to be in a meeting to speak to all of you. Dr. Junaid here is a very good friend, and Dr. Ihan, we worked together in American Hospital long ago. So I listened to Dr. Khalid Haq last week, an excellent lecture, and I'm happy that he's here today as well. So good evening, Dr. Khalid. And I'll just start the presentation just to say that obviously I'm not an expert in the topic, but I'll try to present it in a way that is useful to all of you. I know it's a bit of theory as well in it, because you need to cover the topic as best as we can. We will try to make it interesting, and I'll try to finish by 45 minutes, after which we'll have some discussion. So we all know that jaundice in itself is very common. 60% of term babies and nearly 80% of premature babies have jaundice. In majority, it resolves by 2 weeks, but in about 2 to 15% of newborns, depends on which population you're looking at, jaundice can be observed even at 2 weeks. Jaundice persisting beyond 2 weeks in the term formula-fed babies and over 3 weeks in premature babies and in term breastfed babies is called prolonged jaundice. So this improvement for the breastfed babies is to avoid overscreening. Just a quick recap. I mean, you're all familiar with bilirubin metabolism. So the red blood cells are broken down in the reticuloendothelial system. The heme mainly comes from that, and you also get other sources of heme from heme protein, myoglobin, and other heme-containing proteins. So this is acted on by heme oxygenase to biliverdin and biliverdin reductase to bilirubin. Bilirubin mainly binds with the serum albumin. It passes by the liver, where it is taken up by the liver cells using the ligand in protein. And in the smooth endoplasmic reticulum of the hepatocytes, it undergoes conjugation with glucuronidase transferase, and the bilirubin glucuronide is excreted in the bile. This partly gets broken down through beta-glucuronidase and reabsorbs through the intrahepatic, but most of it comes through in the bile. Conjugated bilirubin doesn't enter directly into the bloodstream unless there is a problem in the liver. And if there is no conjugated bilirubin, the urine is acholic or clear. While if there is conjugated bilirubin, so urine gets dark yellow. So if you have an yellow urine with pale stools, it's very typical of conjugated jaundice. We know that bile secretion is an essential function of the liver. The bile acids are delivered to the intestine, and its role in lipid solubilization and absorption is important. In addition to the bile acids, we also have metabolic products like cholesterol, bilirubin, which we just discussed, the porphyrins and xenobiotics, which are chemicals which are present in the body, which doesn't belong to the body. They are excreted as well in the bile. So you know that the liver is one of the metabolic systems as well as excretory system in addition to the kidneys. The bile acids themselves are formed via multiple complex steps in the degradation of cholesterol. The main bile acids secreted in the liver are cholic acid and chenodeoxycholic acid. We all know that ursodeoxycholic acid is also used to treat as a cholinergic agent and also to replace bile acids. Extensive conjugation with primarily glycine and taurine occurs in the bile acids as well within the hepatocyte. The bile flow can be divided into bile acid dependent and bile acid independent flow. So we call the bile acid dependent as cholinergic flow, and any medicine with a function which stimulates the bile secretion is cholinergic. So the primary force comes from the bile acid dependent pathway. This is a quick recap. I mean, this is the liver architecture, and this is the segment that we are zooming in on. So we have the hepatocytes, we have the bile canaliculi, and you have the tight junction between the two. And sometimes you have problems in the tight junction protein, which may lead to bile acid release defects. We also have problems in the bile acid interchange mechanism through the bile canaliculi, which is related to the familial progressive disorders. And we have the sinusoid, the secretions go into that. Subsequently, you can see the architecture of the liver as well. So we have the central vein at the center of the hepatic lobule. We have the hepatocytes radiating out, and at the outer part you get the portal triad. So we have the portal vein, portal artery, and the portal bile duct in the portal triad. In this, obviously, there is no fibrosis, but in the abnormalities, which we will discuss later, we will start getting fibrosis as well. So this is just to introduce you to the basic anatomy of the liver. It's helpful to understand also that direct and conjugated bilirubin are actually different. They don't mean exactly the same. And it depends on the direct reaction before addition of an accelerating agent. So the common test is the Diazo or the Vandenberg method. And this doesn't specifically measure the conjugated bilirubin, but it measures the direct bilirubin, which reacts with the reagent before an accelerating agent is added. So the direct bilirubin includes conjugated bilirubin and delta bilirubin. And because of this factor, the direct bilirubin often goes up when the total bilirubin goes up suddenly. So you are screening a baby with jaundice around day 3, day 4, you see a sudden rise in the total bilirubin to 20, for example, from 15. And then the direct bilirubin goes up from 1 to 3 suddenly. But the next day, if you repeat, the direct bilirubin starts coming down. And that is because when the bilirubin goes up acutely, the fraction that is unbound to albumin, the delta bilirubin goes up as well. So that is why hemolytic jaundice, for example, has a very high risk of brain damage. If it's going up too rapidly, it overcomes, and the delta or free bilirubin is high. Direct bilirubin concentrations are higher and more variable than the conjugated bilirubin. And so you can say that conjugated bilirubin is more accurate, but it depends on what lab test your lab is doing. So if we are specifically measuring conjugated bilirubin, well and good. But if they are doing the direct bilirubin, we accept that as well and accordingly work on it. So jaundice is clinically evident when the total serum bilirubin exceeds 2.5 to 3 milligrams. So below 3 milligram, you would not pick up jaundice. And this is the criteria for which we screen the babies at prolonged jaundice review. I told that for breastfed or preterm babies who are still jaundiced at 3 weeks, if they're visibly jaundiced, that is if the level exceeds, or you do a transcutaneous bilirubin and it is above this cutoff, that is when you consider doing the total and direct bilirubin fractions so that you can identify pathologic cholestasis at the earliest possible. So you must have seen the recent AAP guideline update for neonatal jaundice. In that, the comment made about direct bilirubin is using the North American and European Society for Gastroenterology, Hepatology and Nutrition. They define a direct serum bilirubin more than 1 milligram per cell as normal. If they're using conjugated bilirubin, they use a level of more than 0.3 milligrams per deciliter. The positive predictive value for biliary atresia and other causes of pathologic cholestasis can be greatly improved if you repeat the measurement within a few days to 2 weeks. So you're picking them up at 2 weeks, then it's okay to repeat it after a week or so to see the trend if it is borderline. But you don't want to miss it beyond 3 to 4 weeks, because earlier the diagnosis is made, the quicker you can initiate the pathway to treat. An increase in the direct or conjugated bilirubin concentration suggests the possibility of pathologic cholestasis. And here again, the previous possibility of direct bilirubin more than 20% of the total is no longer regarded as necessary, because by the time you see these babies, I think someone is not muted. Can you mute yourself? So direct bilirubin concentration of more than 20% of the total is no longer regarded as necessary for the diagnosis of cholestasis. It's also important to consider other causes that can be treated apart from the biliary atresia. So urinary tract infection, isoimmune hemolytic disease, sepsis, and some inborn errors. So we will be discussing in the following slides our basic approach, and then we will deal with each one of these conditions as far as possible. So in my practice, as well as a recommendation from the other guidelines, it's a good practice to include conjugated or direct fraction of bilirubin at initial assessment. So the first time you do a blood test for jaundice for whatever reason, include the conjugated fraction in it. At least you'll have a baseline, and as I will discuss later, there are studies which show that the direct bilirubin fraction is slightly high in the babies who are picked up later having abnormality. And once a baby is reviewed at 2 weeks or at the first opportunity around that stage, it's ideal to do if the persisting jaundice is there. If it is a breastfeeding baby, we could wait another week till 3 weeks. But if you are worried about a missed opportunity, you can as well do it at 2 weeks. It's not going to change. If the trend is increasing, you would pick it up at that stage. So it's not hard and fast that you should wait till 3 weeks in a breastfed baby. You can do it at 2 weeks for any of these categories. And the later you do and you prove that there is no conjugated fraction, the safer you are. So you also review the newborn screening results. We have hypothyroidism, galactosemia, tyrosinemia, and cystic fibrosis often included in the newborn screen. It depends on where you practice and what tests are included. So be clear about what is included in your panel. And if a baby has suspected abnormality, the regional labs, for example, in Abu Dhabi, we have Tawam Hospital in Alain, where we can send for the extended newborn screen and they can report in within 24 hours in such cases. We should be clear about differentiation of categories of benign jaundice, because most of the babies with prolonged jaundice have this benign jaundice. So we have physiologic jaundice, which we are clear that it starts by 24 to 36 hours. It peaks by 3 to 4 days, and the peak is around 5 to 12 milligrams. And by 1 to 2 weeks, most of them go below 3 milligrams per cent, unless there is breastfeeding jaundice. So physiologic jaundice can progress to either of these two. So breastfeeding jaundice is aggravated physiologic jaundice in breastfeeding babies, usually due to reduced milk output, the time it takes for the lactogenesis. The peaks by 2 to 4 days, and the peak bilirubin, that onset is 2 to 4 days, similar to physiologic jaundice, peak by 3 to 6 days. The peak is a little higher, it can be exaggerated, and some of these babies may need treatment. Of course, you need to attend to the feeding sufficiency as well. And these babies usually have a component of breast milk jaundice in some of them, because these are mainly breastfed babies, and the jaundice may persist more than 3 weeks. In incidence is 12 to 13%. Of course, breast milk jaundice is due to the beta-glucuronidase, which is secreted in the milk of some of the mothers. So it's fairly not very common, but not uncommon as well. So 2 to 4% of the babies will have breast milk jaundice. And here, actually, you have a level more than 10 milligrams persisting for a few weeks. So I've seen babies where the bilirubin is like 12, 13 milligram even at 2 to 3 months of age. And all that we do is monitor the bilirubin on a regular basis. There is no indication in any of these conditions to supplement with formula or to disrupt breastfeeding, unless you are needing, you're approaching a level close to exchange transfusion. Of course, you can treat with phototherapy if it crosses the phototherapy range for that age of the baby, but you don't need to disrupt breastfeeding. And if you do have to pause breastfeeding for a couple of days, if they're approaching exchange, you can reassure the mother and encourage her to express the milk. This is what we discussed. So breastfeeding jaundice is due to the delayed letdown and reduced calorie intake and relative dehydration. There may be decreased fluid intake and delayed passage of meconium associated. And this is the showing the area where the beta-glucuronidase acts. If the beta-glucuronidase comes in from the milk, it releases the bilirubin from the conjugated bilirubin in the gut, and it can enter the intrahepatic circulation and keeps persisting. It doesn't come out as much in the stool. So here, the only thing we need to do is optimal breastfeeding support from antenatal and immediate postnatal period. And we need to monitor closely for the breast milk jaundice, but don't stop breastfeeding. And of course, if they fulfill the criteria, you should jaundice in babies with persistent or prolonged jaundice. The incidence of neonatal cholestasis is 1 in 2,500 in approximate numbers. Cholestasis is defined as a reduced bile formation or flow, resulting in the retention of biliary substances within the liver. And it can be related to a defect in the intrahepatic production or the transmembrane transport of bile, or it can be a mechanical obstruction preventing the bile flow. The third component, the obstruction component, is the most important to pick up early, and because biliary atresia is the commonest reason for this obstruction. As the bile is not excreted in the stool, we get acholic or pale stools and obstructive or cholestatic jaundice. The kidneys do not filter unconjugated bilirubin because of its avid binding to the albumin, and the presence of bilirubin in the urine, as I discussed earlier, indicates the presence of conjugated hyperbilirubenemia. So a dark urine in the absence of dehydration, obviously you have to think, and it stains the nappy. Typically the bilirubin will be seen on the nappy. So you can ask these questions to the mother while eliciting the history. And I mentioned that it's very important to diagnose biliary atresia early because surgical intervention before 2 months correlates with a better long-term outcome. Despite the best of efforts in many countries, even in the developed world, the average age of diagnosis and treatment is around 60 days. So the causes, this is not exhaustive. Obviously, we can classify as intrahepatic and extrahepatic. Extrahepatic is classified mainly by biliary atresia. Then you have the other minor conditions like mucus plugging, choledochal cyst, and Caroli's disease. Intrahepatic, Alagille syndrome, and the metabolic conditions we'll discuss later as well, and these infections may contribute. So biliary atresia represents the most common cause. Of course, these charts would be different from what is given in most of the textbooks because as time evolves, the diagnosis of the more important, rarer conditions has started increasing. So biliary atresia is in 35 to 41%. So this would be the range 25 to 40% in the olden days as well. However, we have the progressive familial intrahepatic cholestasis, or PFIC, which is seen in 10% now, which was in the idiopathic category previously. In the past 20 years, our knowledge of this condition and the ability to do genetic analysis to diagnose this has improved, and we will be discussing this later on. Preterm birth mostly TP and related cholestasis is seen in 10%. Luckily, most of these are benign. Metabolic and endocrine conditions like hypothyroidism and hypoadrenalism or panhypopituitarism can contribute in 9 to 17%. Alagille syndrome in 2 to 6%. Infections in 1 to 10. Mitochondriopathies. Biliary sludge can happen where you have hemolytic diseases. It can be hemolytic anemias in the family like sickle cell, or it can be sepsis-related hemolysis. You have idiopathic causes still in 13 to 30%. Remember that about 20 years ago, this was around 40-45%. So this has come down significantly because we are categorizing some of the metabolic conditions better. So this is the guideline which I mentioned earlier in relation to the AAP jaundice update. And this is a joint recommendation from the North American Society and the European Society for Pediatric Gastrohepatology and Nutrition. And you have the full text available on the web as well. So there are main parameters that are covered in the history taking. So we have family history, mainly consanguinity and history of neonatal cholestasis in the parents or siblings, which are related to all these autosomal recessive disorders, cystic fibrosis, alpha-1 antitrypsin, PFIC, and Alagille syndrome can also be inherited. If there is a history of repeated fetal loss or early demise, you have to consider gestational alloimmune liver disease. So this is like alloimmune hematological conditions, but here the alloimmunity is to the liver material itself. The main feature here is a very high risk of coagulopathy in the newborn. They often lead to death. Spherocytosis and other hemolytic diseases, I mentioned the risk of biliary sludging, and they can aggravate conjugated hyperbilirubinemia through that. And you look at the prenatal history, the prenatal ultrasound findings may sometimes pick up choledochal cyst. And if there are bowel anomalies or there are syndromes, you may pick them up. And cholestasis of pregnancy can often be seen in carriers of the PFIC gene. So if they are heterozygotes, they might sometimes have cholestasis. So you may have to correlate that if the mother's history suggested. Acute fatty liver of pregnancy is known to be associated with the heterozygote condition for 3-hydroxyacyl-CoA dehydrogenase deficiency. And maternal infections, as we always ask, for torch infections. In terms of the infant history, we have the gestational age, prematurity we discussed as well. Small for gestational age babies have a higher risk of syndromes and intrauterine infections. And we have other conditions which may contribute: alloimmune hemolysis, G6PD deficiency, hydroxyfetalis, which all contribute to increased risk of cholestasis, same as the hemolytic conditions, anemia we discussed. Neonatal infections, urinary tract infections, sepsis, and CMV, HIV, syphilis may also contribute. I told you that you should review the result of the newborn screen because we can pick up galactosemia, panhypopituitarism, fatty acid oxidation defects, and cystic fibrosis, also hypothyroidism. And the nutrition source, if it is breastfeeding babies, galactosemia has to be considered. Formula fed the same way, any lactose containing milk. And if there has been fruit juices introduced, you should consider hereditary fructose intolerance. I've seen one baby in a family, repeatedly the child used to worsen after 3 to 4 months when they started introducing sugarcane juice or other juices into the family. In that family, they were introducing early. And with this history, the child used to develop severe liver failure by 6 to 8 months and die. And this was the 4th sibling that we saw. Luckily, we were able to identify and manage that baby. And you have parenteral nutrition-associated liver disease. Of course, there are other conditions which you can review. Growth is associated with genetic, metabolic, hearing problems, PFIC can be having, or the tight junction protein mutation. Vomiting can suggest bowel obstruction, pyloric stenosis. The level of stooling and the color of the stool is important, and urine characteristics. Excessive bleeding may indicate coagulopathy and the associated vitamin K deficiency with liver failure. And irritability, lethargy is not typically seen in biliary atresia, but it may suggest metabolic disease or sepsis. If there is a history of previous abdominal surgery, NEC and TPN related can contribute, and also intestinal atresia may be associated with bile duct atresia, cholangiopathies. In terms of physical findings, the general health ill appearance may indicate infection or metabolic disease, and typically infants with biliary atresia are deceptively normal. So this is very important. Remember that the biliary atresia babies don't look unwell, so you may easily miss them unless you are really looking for the prolonged jaundice. So in terms of general appearance, we have dysmorphic features in Alagille syndrome. Remember that you may not pick that up in the newborn period. The typical dysmorphism, the broad nasal bridge, triangular face, deep set eyes, and sharp chin, they develop around 6 months of age. In terms of the vision examination and hearing assessment, you have congenital infection, septoptic dysplasia, and you can get posterior embryotoxin in the Alagille syndrome, and cataracts as well in intrauterine infections. Cardiac examination can be a feature of Alagille syndrome. You also get polysplenia and situs malformations in some specific syndromic types of biliary atresia. In terms of abdominal examination, you look for hepatosplenomegaly and abdominal masses, and umbilical hernia may suggest hypothyroidism, for example, or metabolic conditions. The stool examination is crucial, and it's better that you don't go by the parent's description. You try to look at the stool itself to see the color of the stool. We'll be looking at the stool chart as well next in the coming slides. And of course, in neurologic assessment, you look at the overall vigor and tone, because hypothyroid babies or babies with metabolic conditions can have altered tone. So in terms of approach to investigations, we have a targeted approach. So you have tier 1 investigations, which you would do in any baby with cholestasis, and the tier 2 investigations, which you do in liaison with the gastroenterologist in select cases. So the tier 1 investigations we aim to evaluate after cholestasis has been established in order to identify the treatable disorder, as well as to define how severe it is. The urgency of the treatment will depend on that. So you perform blood tests, including the blood count and differential, the clotting profile, AST, ALT, alkaline phosphatase, gamma GT, total and direct bilirubin. So the full liver function panel, albumin and glucose are done as well. So glucose is important for galactosemia testing. It's a good practice to check the alpha-1 antitrypsin phenotype at this stage if you can afford it, because it will help to differentiate from other causes of obstruction. Because on the biopsy, for example, it mimics biliary atresia. Of course, the thyroid and the newborn screen results. In terms of urine, you would do the urine analysis and culture, as well as reducing substances to rule out galactosemia, and consider cultures of the blood, urine, and other fluids if the infant is clinically unwell. You verify the results of treatable disorders from the newborn screen. We also obtain the fasting ultrasound as part of the tier 1 investigation. Once you confirm that the conjugated bilirubin is abnormal, we'll be looking at the ultrasound findings in the further slides. The tier 2, as I said, involve the gastroenterologist and hepatologist if you have not identified the cause in the tier 1 investigations. So again, you have the general test, which you might have already reviewed, the thyroid function. You also include the serum bile acids, cortisol as well. And specific etiologies, you do metabolic panel, serum ammonia, lactate, cholesterol, red blood cell galliput for the galactosemia, urine succinyl acetone for the tyrosinemia and organic acids. And bile salt species testing is important for specific bile salt related disorders. For infectious disease, you can do PCR for CMV, herpes, listeria as well. And genetics, you discuss in liaison with the gastroenterologist, and you can consider the gene panel for many of the recent metabolic disorders, including the progressive, the PFIC conditions. And of course, sweat chloride for cystic fibrosis. Imaging, in addition to the ultrasound, which was done as part of the tier 1 investigation, you do the chest X-ray for looking at lung and heart disease associated syndromes. Butterfly vertebra can suggest Alagille syndrome. Echocardiogram, there are heart diseases seen in Alagille syndrome. Pulmonary stenosis, BSD can be seen, ASD can be seen. And cholangiogram can be considered, which we will discuss as well. Liver biopsy is a differentiation of choice for the intrahepatic and extrahepatic disease. Once you consider extrahepatic disease or obstruction, the intraoperative cholangiogram is the mainstay of investigation. And you might need consultations depending on what you find in the above: ophthalmology, metabolic and genetic, cardiology, pediatric surgeon, and nutrition or dietitian. In terms of the ultrasound, you need an expert operator who is clear about what they are looking for, so you don't miss findings. And you look for the liver structure and size, presence of dilated bile ducts or obstructed bile ducts, gallbladder size, wall thickness, and presence of the triangular cord sign, which I'll discuss next. Identification of the extrahepatic obstructive lesions like choledochal cyst, gallstone, sludge, ascites, spleen size, situs abnormalities, and vascular malformations to look for the syndromic type of biliary atresia. And of course, it's very important. Sometimes the bubble gas interferes with the nature of your study. So if it is difficult to pick up, you can, and usually it's a fasting ultrasound done so that you pick up the gallbladder. After feed, the gallbladder empties, so it's not conclusive. Remember that picking up a small gallbladder is a finding you see in biliary atresia. So the triangular cord sign, abnormal gallbladder morphology, lack of gallbladder contraction after feeding, that means it's fibrosed. Non-visualization of the common bile duct, hepatic artery diameter, the ratio of the hepatic artery diameter to the portal vein, subcapsular blood flow. They have all been suggested to aid, but not none of them can singularly confirm the diagnosis. You cannot just say because the sign is there, it's biliary atresia, but it increases your index of suspicion. And most infants with biliary atresia have a small undetectable gallbladder. So that's why the fasting scan is very important. If you're suspecting panhypopituitarism, because of the risk of the sugar dropping, you wouldn't make the infants fast too long. In addition, findings such as heterotaxy, midline liver, polysplenia, asplenia, pre-duodenal portal vein, they increase the concern of biliary atresia with malformation. And normal ultrasound does not rule out non-syndromic biliary atresia. So this is the triangular cord sign, more than or equal to 4 millimeter thickness of the echogenic anterior wall of the right portal vein. So the echogenic anterior wall of the right portal vein. And it's a triangular tubular area of echogenic fibrous tissue in the porta hepatis. So this triangular area of tissue is a triangular cord sign, and it falls on the anterior margin of the right portal vein, anterior wall. The scintigraphy, we used to study a lot about it, but most people have started moving away from it for the reasons we'll describe here. So it has been used to confirm biliary tract patency, but it is limited by its low specificity. The range is 68 to 72%. And a non-diagnostic result when the bile flow is limited as a result of other variable etiologies. So patients who have the interlobular bile duct paucity, idiopathic neonatal hepatitis, those on TPN may all have non-excreting scans. So that's why the specificity is very low. And obviously, sometimes we used to give phenobarbital for 5 days and wait, and all this delays the actual diagnosis. And that's why they're moving away from the HIDA scans, a lack of specificity and a possible delay from the need for simulation, so on. Yang et al. Had published a study looking at the different modalities to help differentiate obstructive and non-obstructive giant cell hepatitis. 69 infants were studied, and they underwent, all of them underwent these tests. The hepatobiliary scintigraphy had a sensitivity of 88%, but specificity was 45%. And it adds little to the routine evaluation, and it may help to rule out obstruction. So if there is a negative flow, it is highly sensitive, but your specificity is less, so you can't be sure it's biliary atresia. And they found that liver biopsy had the highest sensitivity in detecting biliary atresia and differentiating it from intrahepatic bile duct disorders like Alagille syndrome. It was quite high specificity and sensitivity. You have non-invasive modes of assessing like MRCP, and ERCP, of course, is not invasive, not specifically non-invasive, but it's less invasive. The problem with ERCP is the lack of suitable infant scope, and you need an expert, and it needs anesthesia. Magnetic resonance cholangiopancreography is non-invasive, and you can visualize the biliary system, including the first order branches of the intrahepatic bile duct. So if it is biliary atresia, you may be able to classify it based on the MRCP. It has a high sensitivity, but again, it's a low specificity. And we also have, if you're doing a liver biopsy, some centers may consider percutaneous transhepatic cholecystocholangiography, but most of them don't do it because the same information is often obtained by the liver biopsy result, and you don't get much additional findings. And of course, it's more invasive. As I said earlier, liver biopsy is the cornerstone of the diagnostic workup. It's very important that an experienced pathologist looks at it, and the sensitivity is quite high in these cases as well as specificity. There are some disorders that mimic biliary atresia histologically, and these include the parental nutrition-associated cholestasis. So if it is a premature baby, you need to have an extra index of suspicion because the biopsy may overlap with biliary atresia, and you need to do the intraoperative cholangiography if you're worried. Cystic fibrosis, alpha-1 antitrypsin may all be associated with a similar biopsy picture. The earliest histologic changes of biliary atresia are relatively non-specific, and biopsies which are performed too early in the course may result in a falsely negative diagnosis. So again, just like a normal ultrasound doesn't rule out, a normal liver biopsy also doesn't rule out, and you need to continue to watch these babies and have a low threshold to go for intraoperative cholangiography if in doubt. So the liver biopsy, as you know, is often challenging to perform. It needs an expert review. The tissue has to be properly saved and taken to the lab. Sometimes you do the biopsy, and the way you are transporting it, you may lose it. And in some inconclusive cases, a repeat liver biopsy a few months later may help as conditions evolve. Of course, this will not apply to biliary atresia. If there is a concern, you would intervene early. And as these babies have insufficient hepatic synthetic function, you may have to give vitamin K in a higher dose initially before you do the biopsy, or you have to test the cholangi because there's a risk of bleeding in 4% of the babies after liver biopsy. So these are slides from patients with biliary atresia, and you can see very well that the normal sinusoidal pattern is preserved, but you can see fibrosis in the portal tracts. The bile ducts are exaggerated and they are blocked. So you have features of bile duct obstruction, bile duct proliferation. So you can see multiple bile ducts in the same field, bile plugs obstructing the bile ducts, and you have perilobular fibrosis and edema. Sometimes you get infiltrates of cells. Remember that giant cells are not specific for giant cell or idiopathic hepatitis. There are 20 to 50% of babies with biliary atresia. Some of them may have giant cells as well. And this is what you get with idiopathic neonatal hepatitis. And this picture is not specific, as we see giant cell hepatitis pattern is seen in quite a few metabolic and infectious conditions as well. So here you have lost the sinusoidal pattern, you have inflammatory infiltrate and the giant cells. We discussed earlier about intraoperative cholangiogram and histological examination of the duct remnant at the time of the surgery. You may do a frozen section of that. So this is the criterion standard to diagnose biliary atresia. This is the only test that can clearly rule out the condition or confirm. Unfortunately, it is invasive, and that may be the only option you have. And that's why we don't do the HIDA scan. If the liver biopsy is not able to be done also, you still have to go for this if the suspicion is strong. So cases which have a hypoplastic biliary tree, like Alagille syndrome and cystic fibrosis, can be confounding in up to 20% of the cases. So it's important that you rule out these two conditions before you actually take the patient to the OT. And intraoperative cholangiogram is typically performed after biliary obstruction is suggested in a liver biopsy, or if there are other clinical conditions, then direct referral to the surgeon can be done. And of course, you go prepared, you get the consent, and you explain to the family that if biliary atresia is confirmed, you would do the Kasai procedure on the table. So there are very few exceptions to this because you don't want to expose the patient to anesthesia again, and you don't want to delay further. So if you are doing intraoperative cholangiogram, you go prepared to do the Kasai if you confirm the diagnosis. So there may be a slight repetition just for the sake of covering the aspects specific to the conditions now. So biliary atresia is the most frequent and severe cause of neonatal cholestasis. And biliary atresia is basically an ascending inflammatory process of the biliary tree, leading to progressive obliterative scarring of the extrahepatic and intrahepatic bile ducts. And this leads eventually to biliary cirrhosis. So most of these babies die by 3 to 4 years untreated. Only early surgical treatment can stall the biliary cirrhosis, and that's where rapid identification is important. The exact etiopathogenesis is unknown. Environmental factors, infection, and genetic factors may play a role. It can be related to alloimmune events expedited by microchimerism in the mother. And there are infections like CMV reovirus which are shown. And some people hypothesize that sclerosing cholangitis or sclerosing diseases are a spectrum with biliary atresia. So some of them develop the severe type, some of them develop it later. The fact that the conjugated bilirubin can be raised in the first bilirubin screening in such babies indicates that the onset of the problem may be antenatal in many of them. So infants present with conjugated hyperbilirubenemia, as we said, depigmented or pale stool, colored urine, and your investigation would show conjugated jaundice, elevated liver transaminase, including GGT. Abdominal ultrasound performed early will show you the features which we discussed. The triangular periportal sign is fairly sensitive and specific if you do with an expert. And pre and postprandial ultrasonography facilitates the gallbladder contraction as well, or the absence of it. Obstructive conditions like choledochal cyst, Caroli's disease, gallstone, or inspissated bile or biliary cast can be seen on ultrasound as well. The diagnostic gold standard is percutaneous liver biopsy followed by intraoperative cholangiogram if it is inconclusive, or you need to go in for the surgery. And liver biopsy leads to the diagnosis in 80 to 95% of the cases. Histology we discussed already, and you see inflammatory infiltrates around the bile duct, portal tract fibrosis, accumulation of the bile with bile plugs, and bile duct proliferation. ERCP may serve as a reliable and safe diagnostic tool, but again, technical difficulties will be there. And HIDA scan is associated with high sensitivity but lacks specificity, so it's not often done. So the incidence is 1 in 8,000 live births, and in US, for example, it's 400 cases per year. It's the most frequent indication for liver transplantation in children. And we have 3 different types. The isolated type, which is 80% of cases, they have a jaundice-free interval after birth, and so you may not pick them up. The syndromic forms may be associated with polysplenia or situs inversus, and these babies are frequently jaundiced, and the initial test itself may show a raised conjugated bilirubin. And you have the cystic form in 5%. The etiology, as we discussed, is not clear. Viruses may contribute, toxins, immune systems. And Kasai procedure is crucial before 4 months, so diagnosed before 2 months. Between 45 and 90 days, the prognosis gets worse as you delay. And if you don't treat it, cirrhosis develops by 6 months. And as I said, early death is common. These are the 3 types pathologically. So we have the type 1 in 5%, type 2 in 2%. Type 1 has a gallbladder which contains bile, and we often have the common bile duct, but the intrahepatic ducts are not developed. And in type 2, we have a visible patent ductus at the porta, but beyond that, it is atretic. and the gallbladder is atretic as well. And the commonest type is a type 3, where very fine intrahepatic ducts are seen, but apart from that, nothing else. So this is the type where you do the portoenterostomy and hope that it works, but it may not work in many of these babies as well. The reason we do it early for the treatment is because it can be a progressive condition, and in the early stages, the response is better. So the hepatoportoenterostomy to enable the biliary drainage is the first line of the treatment. The success rate is closely associated with the age at the time of the surgery. If it is performed within the first 60 days, 70% of the babies will establish bile flow. After 90 days, less than 25%. And so if the bile flow is not established, the progress to cirrhosis will continue unless you do a liver transplantation. And by native liver, we mean the number of babies without the liver transplantation. So if surgery is done within the first 2 months and it's not been still achieved, and you can monitor the success by normalization of conjugated bilirubin and AST 2 months after the surgery. This is to illustrate how the Kasai procedure is done. So this is the absent bile duct or the drainage into the second part of duodenum. So you're basically transecting the intestine here, connecting the proximal end of the intestine into the porta hepatis area, hoping that the bile ducts which are atretic start draining into it, and the duodenum is anastomored side on to this portion of the intestine. So that's why it's called a Rau-NY portoenterostomy. So to facilitate the early diagnosis in Taiwan, a stool car system led to a decline of late referral. And this is one reason why it's regarded as simple and promising screening approach. And consider adding direct bilirubin in the initial part, as we said. And in a large series which examined 743 infants with Biliary Atresia, this is the survival rate. So we see that it progressively drops, and still even with a reasonably successful procedure, you still need liver transplant. Of course, the success of the liver transplant and the ease of doing the procedure becomes better as a child survives longer. Survival rates with native liver decreased and age at surgery increased from 45 days to 90 days, and early diagnosis and treatment is key. So this is the stool car test. I would suggest that all of you keep a copy of it in your clinic and also discuss with the family. So any pale colored stool is abnormal, and you have different consistencies and textures of normal stool. So we discussed this already, that you can diagnose by looking at the conjugated jaundice in the early newborn period. So they looked at it both retrospectively, in which case all the 34 babies with Biliary Atresia had raised conjugated bilirubin, and prospective evaluation of more than 11,000 newborns, they found 4 cases with cholestasis. Quickly moving on to the other differentials. So choledochal cysts account for 2 to 3% of infants, and they are surgically treatable. There are 5 anatomic variants, of which type 1 with 50 to 80% of the biliary cysts. And this is more common in Japan for some reason, but in the rest of the world, it's 1 in 50,000 of the live births. 4:1, more common in females, and abnormal pancreatobiliary junction is often seen. You should not confuse the cystic type, which is 5% of the biliary atresia cases, with the choledochal cyst. Of course, the pathology is different, and the liver is normal here, while the liver architecture is abnormal. So the liver biopsy would help you if you have a doubt. You might have heard of Caroli's disease. It's associated with the multifocal dilatation of the medium and large intrahepatic bile duct, but the common bile duct is not affected. So ultrasound will show dilatation in the liver itself, but not the bile duct. And usually it may be limited to one lobe, mostly the left lobe. And the Caroli syndrome is Caroli's disease associated with celiopathies, and you may have abnormality with autosomal recessive polycystic kidney disease, juvenile nephronophthisis, Joubert syndrome, and so on. You can diagnose by ultrasound, ERCP or MRCP, and this responds to ursodeoxycholic acid, and the final treatment is curative by liver transplantation. We quickly mentioned about TPN-associated cholestasis earlier, and it's a common cause of cholestasis in preterm babies or babies with short gut who need TPN longer than 2 weeks. Infection could add to this, and the TPN components, both amino acid and lipid preparations, could contribute. There are recent studies which show SMOF, which is a combination of soy, MCT oil, olive oil, and fish oil, to reduce the risk of cholestasis in babies who need long-term TPN. But it's not a major benefit, but it could help. CMV infection might be an additional factor in the extreme premature babies. And in most babies, this improves in a few weeks. So just monitoring and seeing the trend is adequate. And remember that the pathology, the liver biopsy findings overlaps with biliary atresia, so it can be confusing. Because biliary atresia can happen in premature babies as well, the approach is not different. So if a premature baby has persisting jaundice and you are worried, you should approach it the same way as in a term baby. Don't let this conflict your opinion. So this is the picture. As I said, it overlaps a lot. The portal triad is preserved. The sinusoidal pattern is preserved. You often get inflammatory infiltrates coming up. So idiopathic neonatal giant cell hepatitis is a non-specific term, and it's a differential diagnosis of exclusion after you have ruled out the other causes. And the histologic findings are non-specific. Syncytial multinucleated hepatic giant cells are seen. Variable level of inflammation with infiltration of lymphocytes, neutrophils, and lobular cholestasis. It can be seen in other conditions like PFIC and alpha-1 antitrypsin. So these are the different conditions where you can get giant cell hepatitis. So it can be idiopathic in 30% of the cases. Infections can contribute, and biliary atresia in 20 to 30% of the cases. You can have metabolic conditions, alpha-1 antitrypsin, NEMA and PIC, bile acid synthesis disorder, progressive familial intrahepatic cholestasis or PFIC, and endocrine disorders, chromosomal and immune conditions. Alagille syndrome accounts for 2 to 6% of infants with neonatal cholestasis. I don't know how many of you have seen. I've just seen a couple of babies with Alagille syndrome, and as I said, the neonatal phases is not very clear. The liver histology, intrahepatic paucity of bile ducts is seen, and bile ductular proliferation is absent here. Mutations in the JAG1 gene are responsible for 90%. So you have a genetic diagnosis, and you may also have Notch2 receptor mutation in another 10%. So you have broad forehead, deep set eyes, a pointed chin. So the face is triangular. We have the ocular embryo taxon, cardiac anomalies, butterfly vertebra, and facial appearance may only manifest by 6 months. The minor criteria are growth delay, developmental delay, renal cysts, renal artery stenosis, pancreatic insufficiency. There is a risk of hepatocellular carcinoma, and so you would screen them with alpha-fetoprotein and ultrasound every 6 months. So once you have Alagille syndrome diagnosed, this is similar to Beckwith-Wiedemann syndrome, where we do the screening for Wilms tumor. So here we screen for hepatocellular carcinoma. So this is a typical triangular face, the deep set eyes and the chin, which is pointed. Another child, you have the butterfly vertebra, so you can see the fusion in the middle. So how it is appearing here. The posterior embryo taxon is an anteriorly displaced Schwalbe ring, and I have not seen this myself clinically. We have to differentiate cholestasis from bilirubin excretion disorders. So the non-cholestatic entities. So we have Dubin-Johnson syndrome, where the biliary excretion of conjugated bilirubin is impaired, and Rotar syndrome, where the storage of conjugated bilirubin is impaired and the bilirubin leaks into the blood. So both these are causes of conjugated bilirubin rise, but that is not cholestasis. So the rest of the enzymes and GGT and everything will be normal. You can differentiate by urinary coproporphyrin analysis. We have the progressive familial intrahepatic cholestasis as a group of contributing to about 10% of the conditions. As I said earlier, these are newly diagnosed entities. There is alteration in the hepatocellular bile acid transport system. We discussed in the initial couple of slides about the canalicular system, how the bile acid transport from the hepatocyte to the canaliculum happen. So it is autosomal recessive disorders. We have 3 main types. The PFIC 1 and 2 appear in the first months of life, and PFIC 3 later on. And there is also a difference that PFIC 1 and 2 typically have a low gamma GT compared to the other causes of cholestasis. So this is a key differentiating factor. And that's why we add the gamma GT in the investigation of these children with cholestasis, because if the GGT is low, it's not the typical obstructive cholestasis. You start looking into the genetic panel for PFIC or the bile acid secretion disorders. In the PFIC type 3, the GGT is normal. And the diagnosis is based on specific immunostaining as well as by genetic panel testing. You can use ursodeoxycholic acid as a cholinergic agent to postpone bile cirrhosis. An early partial external biliary diversion may normalize serum bile acid, because pruritus is a very common manifestation in these babies. And by performing this procedure, you may delay the worsening and also reduce the pruritus. liver transplantation will be needed in these babies as well. And we have metabolic disorders, 5% of the neonatal cholestasis. So cystic fibrosis, alpha-1 antitrypsin deficiency, which is a PA, is a DZ phenotype. It can present with early onset progressive liver failure and transplantation is needed. Of course, the other types may present with emphysema. So the liver disorder is seen in PA, is a DZ phenotype. We have Gaucher's disease, Niemann-Pick type C, and tyrosinemia type 1, galactosemia, hereditary fructose intolerance, as we discussed earlier. And lastly, the low GGT conditions include bile acid disorders. So abnormal bile acids will be some bile acid synthetic disorders where abnormal bile acids are seen in the urine. Diagnosis is by mass spectrometry, and they can be treated by primary bile acid replacement. So chenodeoxycholic acid replacement might help in these conditions. So this is another useful reference which you can review, and it gives a good explanation of PFIC and other conditions as well. Just to finish up by again the flow chart, I mean, we have prolonged jaundice with direct hyperbilirubenemia. You look at the stool color. If the stool color is pale, your urgency is much more. But of course, this doesn't rule out. You still have to watch them. And basal lab chemistry fasting is done and ultrasonography fasting is done. And you look at these conditions. You go on to liver biopsy, scintigraphy or ERCP is not often done. If liver biopsy is suggestive, you go for intraoperative cholangiography and possibly Kasai. And if the stool color is normal, you go for basal lab chemistry and ultrasonography. And you have to consider more of the non-obstructive conditions, but you cannot rule out obstruction. You may still need to do liver biopsy to exclude. In terms of management, we have vitamin K and multivitamins with higher dose of the fat-soluble vitamins because the fat absorption is deranged. You need high calorie intake as well as use of MCT to bypass the lack of bile because MCT doesn't need bile for absorption. Ursodeoxycholic acid helps in ameliorating the cholestasis, improves the bile flow. By improving the bile flow, it can also displace the toxic bile acids from hepatocytes, reduce the bile acid-related pruritus in some of these babies. In older infants, rifampicin can be used to treat the pruritus, though the mechanism is unknown. It's also possibly an enzyme stimulator in the liver, and like phenobarbital can be considered to use. Antihistamines are not very useful. And if medical treatment fails and pruritus is very severe, you may do a partial biliary diversion. So biliary drainage through a stoma or a partial ileal bypass, the bile duct taken into the ileal area. It can reduce the cholestatic pruritus, and there is treatment specific for the etiology, which will depend on whether it's a urinary tract infection, galactosemia, metabolic conditions, and of course, Kasai for Biliary Atresia. For the PFIC conditions, unfortunately, no specific treatment. It's only the UDCA, biliary diversion, and wait for liver transplant. So to conclude, it's very important not to miss conjugated jaundice. A sensible approach to investigations and management is important. Don't hesitate to involve the appropriate experts. Remember that there is a medico-legal implication if you don't pick up the diagnosis on time. So always have in your system a good way to get the newborn screening results. Have a system to review these babies around 2 to 3 weeks. So you screen them. Most of the time I do the transcutaneous bilirubin. If it is above 50, I tend to do the blood test for prolonged jaundice screen. And once you do the direct bilirubin and it is normal, and if they are breastfeeding, you just support them and don't worry about it. If it is borderline, you may repeat it and then proceed with the investigations as well. So now we will have some discussions. Thank you for the opportunity again.
Thank you so much, sir, for a very nice presentation. So we are starting our questions and answer session. So here is a 3 questions. Number 1 is there any role of phenobarbital in case of conjugated hyperbilirubenemia?
Phenobarbital induces the liver enzymes and it also acts like a partial cholinergic agent. So, as I said, the only indication we used to use is to stimulate the secretion before you do the HIDA scan. For the treatment, there is no real role, and don't delay the diagnosis of important conditions. Even for the pruritus, phenobarbital has been studied, and ursodeoxycholic acid is much more effective than phenobarbital. And of course, you all know about the side effects of phenobarbital. So it's not recommended as a treatment. Of course, if you don't have any options like rifampicin and UDCA alone doesn't help, you can't do the biliary diversion, then you can consider phenobarb to reduce the pruritus, but the effect is less. And as I said, the HIDA scan is not recommended that much these days. You go direct for the liver biopsy.
Right, sir. So second question is, why color of stool is acholic in case of conjugated hyperbilirubinemia? Why not in unconjugated case?
What is the initial part again?
Sir, why color of stool is acholic? Why stool color is changed?
I explained that conjugated bilirubin doesn't enter the blood normally. So conjugated bilirubin comes from the canaliculus into the bile duct and directly coming into the stool. And if the bilirubin has to enter from the stool into the blood, it is after the beta-glucuronidase breaks down the conjugation. Right. Conjugated bilirubin only enters into the bloodstream if the hepatocyte is damaged or there is an obstruction. So unconjugated bilirubin doesn't cause, the color of the stool comes from the bilirubin, and the lack of the bilirubin coming into the stool from the obstruction is the reason for the acholic stools. Same for the urine, because urine, the blood doesn't have conjugated bilirubin, and there is no conjugated bilirubin in the urine for the same reason, because the kidney cannot filter what is not there. But if there is obstructive jaundice, you get bilirubin, conjugated bilirubin in the blood, and the urine may get it as well. So color of the urine being yellow, deep yellow with stains and nappy, and lack of bilirubin in the stool. That is a sign that the bile is not coming into the intestine.
Right, sir. So third question is it necessary acholic stool in case of the biliary atresia?
Acholic stool in case of biliary atresia? As I said, we should have a high index of suspicion, and if there is acholic stool, it points to an obstructive etiology more often, but other causes of intrahepatic paucity or Alagille syndrome may be associated as well. So it's not very specific, and many cases of neonatal hepatitis may have pale stool in the beginning as well, and it improves with time. But in biliary atresia as well, it may be a delayed sign. So it doesn't need to be, depending on the severity of the obstruction. It's a progressive condition, so an absence doesn't rule it out. If you have conjugated bilirubin, you start working up, and the ultrasound, for example, might guide you, and then you go for liver biopsy to differentiate if you don't have any other option. So most of the babies with biliary atresia will have pale stools as the time progresses.
All right, sir. So another question is from Dr. Hanifullah. For how much time we will give ursodeoxycholic acid?
So it depends on what you're treating. If it's a TPN related cholestasis, for example, we give it till the direct bilirubin becomes less than 2 or something, and the baby is not otherwise symptomatic. You see a progressive improving trend. If you're treating a long-term condition like the PFIC or the bile acid synthetic disorders, you would need to continue it long-term. So Caroli's disease also responds to UDCA, and in bile acid synthetic disorders, I'm not sure what products are available, but if you give the specific chenodeoxycholic acid or cholic acid, it responds better. So we have different options, but the duration will depend on the condition you're treating. So the biliary atresia, obviously, once the baby has a surgery, you would not continue it. We are talking of idiopathic neonatal hepatitis. You continue it till the child has conjugated bilirubin staying high.
Right, sir. So second question is from Dr. Alauddin Malik. He's asking, in progressive familial intrahepatic cholestasis, when enzyme normalize, and can we stop also urodeoxycholic acid?
No, unfortunately, these are potentially fatal conditions unless you do liver transplant. So it's not a reversible condition.
Okay, right, sir. So second question is from Dr. Naila. She's asking, how do you treat breastfeeding jaundice?
I explained that in the beginning, and basically breast milk jaundice and breastfeeding jaundice are different. Breastfeeding jaundice is where you just support the feeding of the baby. You make sure the lactation support is there. And breast milk jaundice is where after 2 weeks, the jaundice persists at a high level. And this is due to the beta-glucuronidase in the breast milk. Here also, you have to reassure the mother. And I'll share the link to my YouTube channel. And this information is there in the Zoom chat. I don't know if everyone can access the Zoom chat. So there are specific videos, as Dr. Saeed mentioned at the beginning, including the breast milk jaundice and breastfeeding, and most of these topics are covered as well.
Right, sir. So I think questions right now.
So I don't have access to the chat, or I mean, I'm seeing the question and answer. Let me see.
So Dr. Khalid Haq bhi hain yahan pe, Dr. Khalid and Dr. Sajjad bhi hain. If agar ke wo kuch kehna chahe. Sir, can you hear us?
Yeah,
I can. I think it is a very, very good presentation. Thank you for a very complex subject, and you covered it beautifully. I am very grateful. I learned quite a lot today. Thank you.
Thank you. Thank you so much.
Yeah, I wanted to say the same thing, Dr. Sridhar. This is Dr. Sajjad speaking. Thank you very much for this extensive review of a subject which is a little bit poorly understood, but we learned a lot. We really appreciate your participation. Thank you very much.
Thank you. Pleasure having both of you listening as well. Thank you.
Dr. Vikram, sir, आप कुछ कहना चाहेंगे sir?
But yes, I want to pay thanks to Dr. Sridhar. Thank you, sir. Thank you very much.
Thank you, Dr. Vikram. Nice to see you in person. I mean, we meet on the Facebook.
Yes.
And
we will inshallah arrange further sessions and improve our more discussion and collaboration.
Thank you. You are doing a great job. So congratulations.
Thank you. Thank you, sir.
Sir, another question from Dr. Aladdin Malik. So he's asking, what is prognosis of autoimmune neonatal hepatitis?
I mean, unfortunately, I don't have much experience. Dr. Khalid, do you have any comments, or Dr. Sajjad?
The prognosis is actually not very good, I'm afraid. Even certainly medium-term prognosis and long-term is bad. Even short-term, it's sometimes very, very difficult to treat.
Sometimes use steroids in that, isn't it? I don't
Yes,
have experience.
It doesn't really. I mean, steroid is somebody we always use as a last measure. If nothing, we don't know anything, we add steroid, but it actually doesn't work that much.
Yes.
Right, sir. So I think questions are completed. If anybody wants to ask any questions, so most welcome.
I just want to say thank you again. Thank you again. Thank you very much.
I really enjoyed your lecture last week. And of course, Dr. Sajjad often visits us in UAE. And I had the fortune to meet him many times. Thank you, Dr. Sajjad. And Dr. Khalid.
Thank you very much. We'll see you in Abu Dhabi, inshallah.
Yeah. I
yes,
mean,
of course it was.
Thank you.
So
thank you very much.
Thank you. Good night.
Yeah, please do join us in the academic neonatology group.
Certainly.
And we'd love to have your discussion. Maybe, Saeed, you can forward me the...
I mean, I was telling him that because of the busy schedule, I mostly catch up on YouTube after the session. Live sessions, I hardly ever join because of the time commitments. Because I live in Abu Dhabi, I mean, live in Dubai and work in Abu Dhabi. So it's a bit of a commute, and it's, but I will be, I'll comment on the YouTube, and even Professor Huck's talk I watched last week on recorded session.
Thank you very much. That's great.
Good night. Bye.
Thank you.
Good night.
Thank you.
Good night.
Good night. Assalamu alaikum, everybody. Thank you.
So, thank you so much, sir, for such a nice presentation. And I would like to pay thanks on the behalf of our whole team. आपने टाइम दिया और इस बिजी शेड्यूल में, और जो है हमने बहुत कुछ लर्न किया. एंड अगेन वी विल कीप इन टच विद यू इन फ्यूचर एज वेल फॉर दिस काइंड ऑफ एकेडमिक एक्टिविटीज. सो
आज फुटबॉल का सेमी क्वार्टर फाइनल चल रहा है ना. To catch up on the results. Thank you.
Sir. So our next week session will be on the neonatal hypoglycemia, and our speaker will be Dr. Shabina Arif. She is from AKU. So inshallah, we will meet again in next week on Friday. So thank you so much, sir, and thank you all of you. Good night, sir. Thank you. Thank you.